Hello, everybody, and let's talk today about the uncomplicated urinary tract infection. So we'll start with what does it mean to be an uncomplicated UTI? So a review article from the New England Journal Medicine in 2012 said that this is acute cystitis and pyelonephritis in healthy, premenopausal, non-pregnant women. So if we go on with the definition here, first of all, remember it's the urinary tract that we're talking about an infection in. And a lot of times we think, well, okay, that's the bladder. Well, it's a lot more than that, right? The urinary tract starts all the way up with the kidneys, goes down the ureter to the bladder, and then through the urethra. So really, a UTI is anything infected along this pathway. So you can have an infection in the parenchyma of the kidneys, which would be a pyelonephritis. You can have an infection in the ureters, which would be a ureteritis. You can have an infection in the bladder, cystitis, or in the urethra, urethritis. Remember, it's not just the bladder. It can be anything along this tract. So the obvious thing is, well, an uncomplicated UTI is all the UTIs that are not complicated. But what does that really mean? So we think about what are the complicated UTIs. And first of all, those are ones that are in males. Why is that? Males have a much longer urethra than females, with two sphincters in between there and the bladder. So for a male to get a UTI, a bacteria really has to travel much further up the urethra if we're going to get at least cystitis. So that makes it complicated. Immunocompromised patients, of course, these patients get sick quick. So that would be a complicated case. Pregnant women, because then we have to start thinking about dangers to the fetus. And then, of course, anything that really, in your clinical judgment, is just more serious. So these are things usually associated with stones, because then you can have an infection building up behind the stone in the ureter, sepsis, obstruction related to stents or catheters, anything implanted. We look at the epidemiology here. So this is the most common outpatient bacterial infection that you'll see, especially in internal medicine, family medicine, maybe OB-GYN as well. And as you might think, 84% of all UTIs are in women. Again, why do we think that is? Well, one of the reasons is because of that shorter urethra. There's an annual incidence of 12% in women. And there's one case of pyelonephritis for every 28 cases of cystitis. About 2/3 of the recurrences you'll see are going to be with the same bacteria. So that's important to remember, because as long as that bacteria isn't building up resistance to an antibiotic, you can sometimes use the same antibiotic again. Let's talk about the risk factors here. So we're always taught sexual intercourse is a main risk factor for UTIs in women. This is because when you have intercourse, there's a lot of outside bacteria and flora that can disturb the natural flora in the vaginal urethra area, causing a UTI afterwards. New sex partners, similarly. Spermicide is a risk factor for UTIs. This includes condoms coated with spermicide. And vaginal dryness, I bolded this because this is something that we don't really talk about enough, I think, because it can be fairly simple to treat. In older women, post-menopausal women, really, vaginal dryness is something that can happen after menopause. When the vaginal mucosa dries out, that provides a nidus for bacteria to start a UTI there. And it's really, like I said, simple to treat. How do you do that? Well, topical vaginal estrogen starts to restore that vaginal mucosal barrier. Prior UTIs, once you have one, you're always at a higher risk for a subsequent. There's a history of UTIs in a first-degree female relative. An important thing I wanted to point out here is that recurrent UTIs are not associated with pre- or post-coital voiding patterns. What do I mean by this? A lot of times you'll hear if a woman urinates after sexual intercourse, that lowers the risk of having a UTI afterwards, and that just has not been shown in any studies to actually be the case. There haven't been many great studies on cranberry juice, and the ones that have been done well have not really shown any preventative benefit. So talking about the etiology, the vast majority of UTIs are going to be caused by E. coli, and this is about 75 to 95% of uncomplicated UTIs. Klebsiella is another bacteria you'll see in UTI. Staph saprophyticus, Enterococcus faecalis, and group B strep. And group B strep is the one we're usually testing for in pregnant females. So let's talk about the workup and diagnosis here, starting with the history and physical. So when it comes to your history, what do you want to hear from your patient that might tip you off this might be a UTI? Well, dysuria, what does that mean? Burning or pain with urination. Hematuria, is there any blood in the urine? And then if they say, well, maybe, ask them how to describe it. And the best way I think to describe it is it pink lemonade shade, or is it more of like a red wine, a deeper red? And if it is a deeper red, more of a red wine color, that's a little bit more of a cause for concern, right? Because then we're thinking that's gross hematuria. That takes a lot of blood to have really dark urine like that. Urgency, are they having urine urgency? Do they feel like they got to go, they got to go? And then sometimes when they get to the bathroom and they try to go, nothing or very little actually comes out. So it's just that sensation of having to go. Are they having any abdominal pain, especially lower abdominal pain, kind of overlying the bladder? Is there any discharge, vaginal or urethral? It can be hard to tell the difference between those two on a history alone, but just knowing if they're having any discharge at all, that can be important in your history, your exam, and then your treatment. When you look at your exam, one of the biggest things is SP pain or suprapubic pain, right? So have them lay down on the exam table, palpate over the suprapubic area, over the bladder, and if they have more than pressure, actual pain sensation over there, that can indicate a cystitis. And a pelvic exam when indicated. So when would it be indicated to actually do a pelvic exam or a speculum exam? Well, the main thing here is if they actually report vaginal discharge, right? Because a UTI itself wouldn't necessarily cause vaginal discharge. You can have discharge out the urethra, and then in that case, you could have a urethritis, which is a UTI, right? But like we said before, it can be kind of hard to distinguish if it's vaginal or urethral discharge. So if your patient is reporting, copious malodorous discharge, that's something that you should probably do a pelvic exam on before really just assuming it's a UTI, because what if this is an STD or kind of the beginning of a smoldering pelvic inflammatory disease or something else? And then finally, a lot of times you'll get a urine sample in the office, and we'll talk about that next, but just look at the urine sample first. Is it cloudy? Is it yellow? A lot of times UTIs, the urine will be cloudy. So let's talk about those tests and what we can do. The easiest thing and the cheapest thing really is a urine dipstick. Every office is going to have this. It's extremely cheap, fast, and easy. So literally you have your patient give a sample of urine. You take the paper dipstick, dip it in the urine, and you can look at the colors on the dipstick, and it tells you, what's in it. And the three things we look for really for UTIs are leukocyte esterase, nitrite, and blood. Now, you might be thinking, well, do you need all three? Do you need one? Do you need any? You don't actually need any. You can have a UTI without these, but if you see these, it kind of bolsters that intuition. So it's important to know a negative dip cannot reliably rule out a UTI. In other words, you can have a UTI with a negative urine dipstick. So the next step, look at the urine under the microscope, right? So things we can see there are white blood cells. If you see white blood cells in the urine, that can indicate an infection because those cells are going to fight the infection. But it can be from other things too. Inflammation, right, causes a leukocytosis in white blood cells. And you can also sometimes see bacteria under the microscope. So if you see that, you have a pretty good indication that this could be a bacterial UTI, as long as that was not from a contaminant. And really one of the most helpful things is a urine culture. It's indicated in all cases of pyelonephritis. You don't necessarily have to send a urine culture for every UTI. If this is a simple UTI in a patient who really has not had many UTIs in the past, so you don't have to really worry too much about antibiotic resistance, you may not need a urine culture, right? You may just be able to do a dipstick or microscopy or just on history alone, history and physical alone, and treat it like that. But urine culture can be very helpful in some of those cases where you're not totally sure. You have a patient who has had many UTIs in the past and you're worried about resistance, because the culture will also give you sensitivities to various antibiotics, so you know how to treat it. And then remember what we said before, rule out a vaginal etiology of symptoms. So these can be things like STDs, BV or bacterial vaginosis, or yeast infections such as Candida. We'll talk about treatment here, and you can't talk about treatment without first talking about antibiotic resistance. Antibiotic resistance is not just a factor in UTIs, but all infections and all treatment of infections. Amoxicillin alone, the rates are about 20% plus, and this is in the US. TMP-SMX, you'll see me write this. This is trimethoprim sulfamethoxazole. The brand name is Bactrim. That's about the same 20+%. And then the agents with some of the lower rates, your fluoroquinolones, cephalosporins, and augmentin, which is amoxicillin plus clavulanic acid, less than 10%. And then some of your lowest rates as well, nitrofurantoin, fosfomycin, and mesalamine. Another note here is ESBL, or extended spectrum beta-lactamase bacteria, are on the rise. And these are especially E. coli, Klebsiella, Enterobacter, Pseudomonas, but it can be a lot of others too. So that's one of those reasons where if we're skeptical of an ESBL being the cause, urine culture is really important because then we know what antibiotics that species will be susceptible to. So how do we treat cystitis? Remember, cystitis is an infection of the bladder. First line is nitrofurantoin. You're going to see on these slides that I put in some doses. Depending on the level you're at in training, that may or may not be important. So if you're studying for like step exams or any sort of exams in residence, really, they're not going to ask you to know doses off the top of your head. So I just included the doses here just as kind of a practical note to give you an idea of what kind of course you're looking at, but don't really get stuck on doses. So nitrofurantoin, bactrim or TMP-SMX, or fosfomycin. The fosfomycin can be kind of nice. It's just a one-time dose, but a lot of times it won't be approved by insurance if you haven't tried something else in the past. Second line for cystitis, that's when we start looking at the fluoroquinolone, ciprofloxacin, levofloxacin, and your beta-lactams like augmentin, ceftonir, cefpodoxime. When we're talking about outpatient pyelonephritis is infection in the kidney. So this patient, you see them, they might have CVA or costovertebral angle tenderness. You tap them on the lower rib cage on the sides or the back, and they'll have pain because that's where the kidneys are, right? So first line for this is ciprofloxacin or fluoroquinolone. These are all IDSA guidelines. So cipro or levofloxacin, but ciprofloxacin is the first line. And then second line is Bactrim or beta-lactam. Okay, so what if you have a female patient and it just seems like almost every time they actually have sexual intercourse, they're getting UTIs and they can't, no matter what they do, they're urinating after intercourse, which, like we said, hasn't actually been shown to prevent UTIs, but they just seem to be getting UTIs after intercourse. Well, they can do a prophylactic antibiotic, and this can be helpful. So these are usually single doses that your patient will take before or right after having intercourse to hopefully prevent the start of a UTI. And so this can be nitrofurantoin, it's a lower dose. TMP-SMX, Bactrim again, but this is a lower dose as well. TMP, so trimethoprim by itself, or cephalexin. So what if it's not even just due to having intercourse, but for some reason your female patient comes in and they're just constantly getting UTIs with or without having intercourse, and this can happen often as well. Well, then we start to think, well, is a daily dose needed here? And usually it's given at bedtime. You don't want to jump right to this at the beginning because remember, resistance is a really big thing. And after a while, your patient who's taking the same antibiotic every single day to prevent, well, she could end up getting a UTI with a multi-drug resistant organism now, right? But when we think about these, nitrofurantoin, again, remember these are lower doses usually, TMP-SMX, trimethoprim alone, cephalexin, or fosfomycin every 10 days. I want to close out with some clinical pearls just to remind you of as we finish up here. First is that, remember, UTIs and recurrent UTIs have not been shown to be associated with pre or post-coital voiding patterns. So, I mean, if your patient wants to urinate before or after intercourse to try and prevent a UTI, that's fine. There's no harm in that, but there hasn't been data to show that it actually does prevent UTIs. Vaginal dryness should be treated with topical estrogen regardless of UTI history. So what do I mean by that? Whether your patient is having UTIs or not, if they have vaginal dryness, you should offer to treat that, right? Because not only can it cause UTIs or raise the risk of UTIs, but it can be extremely uncomfortable. It can cause pain during intercourse. It can be a real life stressor. Why would you have your patient experience that if they don't have to? So make sure you discuss that. Some women with symptoms can be managed without an actual in-person visit. So if you have a patient who you know well as a patient, they're reliable, they can give a good history over the phone, and they're telling you, I've had these symptoms in the past, and every time I've had them in the past, it's been a UTI, and you've managed them in the past with this patient. Well, it could be safe to just prescribe this person an antibiotic without actually seeing them in the office. And then finally, remember to delay antimicrobial treatment. So don't just prescribe an antibiotic right away if you have a woman with UTI symptoms and vaginal discharge. You want to wait until you're able to do a vaginal exam and urine culture. So hopefully you're able to do the vaginal exam that day in the office, send a urine culture, and whatever other testing you're doing, whether STI, STD, swab for BV or Candida, and see what that says before necessarily starting some regular UTI treatment. Because it might not be a UTI, right? It could be an STD, STI, it could be a vaginal infection instead. So I hope that was helpful and that you check out some of the other videos, whether it's an ID, it's cardio. We have a bunch of videos that I'd love for you to check out. Until then.